I'd like to understand how quality performance is graded and determined within ACOs. Is it a straightforward calculation based on the reported data, or are there additional factors taken into consideration? Additionally, it's intriguing that there is a small built-in bonus for improving quality over the prior year. Could you provide more details on how this bonus is calculated and awarded?
Wow, great question, Jason. Let's see if I can lose you in this one. The first challenge of the ACOs is to collect raw data from all the practices. And that's data that identifies the denominator, that is the patients or visits eligible for each measure, and then the data that defines the numerator, which is the outcome or intermediate outcome of interest, and is usually clinical in its source. And then once you have the raw data, you need to deduplicate and aggregate patients. So when the patient is seen in multiple practices, you have one measurement. You're looking at the latest or whatever the specifications require for which of the multiple measurements is used to set the numerator. And then once you have that done, calculate the quality performance metrics and submit it to Medicare. Now, there is an improvement bonus, as you've mentioned. Medicare calculates and adds, if earned, a quality improvement score. The requirements of that quality improvement score includes this year's submission has to be complete. It has to have all measures that are required to report. In the case of ACOs, it's the APP, so it's for 2023, it's and 2024, it's the 3 APP measures or the 10 web interface measures. There has to be a score from the prior year. So if you didn't submit for any reason the prior year, you can't be eligible for an improvement score this year. The aggregate quality score this year is then compared to the aggregate quality score last year. It's not on an individual measure basis. It's on that aggregate quality score. And therefore, it can actually compare the web interface measure set against the ECQMs or MIPS CQMs or any combination thereof. It's calculated as a ratio of the difference in scores divided by last year's score. And then that result is multiplied by 10% for a maximum 10% improvement score. Now, only improvement goes into the calculation. If your score dropped and you actually deprecate over those 2 years, that doesn't penalize your score. You only get an improvement score if you actually improve. And it can't drive your total quality score above 100. If you're already running a perfect score or near perfect, that the addition of that quality performance score can't pull you above 100 for the category. Now, there's also, for ACOs, it doesn't happen in MIPS, but it happens in ACOs, there's a health equity adjusted quality performance score. So there's a health equity adjustment that's added to your quality performance score. It's up to 10 points, again, capped at 100, so you can't get above a perfect score. The bonus points are defined by a measure performance scalar multiplied by an underserved multiplier. The underserved multiplier counts the number of patients who are likely to be in an underserved group. And the measure performance scalar compares or groups practices into 3 performance levels: the upper third of performance, the middle third of performance, and the lowest third of performance. Those who are in the third of the upper get 4 extra, that multiplier is 4. Those who are in the middle group get a multiplier of 2, and those in neither of those groups in the lowest third don't get don't get a multiplier. It's 0, so it renders that a 0 bonus. The underserved multiplier relates to what's called an area deprivation index. And there is Medicare tracks, and it's available on the web, a zip code specific area deprivation index that ranges between 1 and 0. So looking at the census related factors in each of those regions, they set this deprivation index. So your underserved multiplier is defined as a proportion of your assigned beneficiaries that are in an area with an area deprivation index greater than or equal to 85. So this is just looking at the address of each individual and comparing it to that national table of area deprivation indexes. And then just counting those that are in an area over 85 and using that in the calculation. Or they also look and use alternately, whichever is a bigger number, the proportion of beneficiaries you care for who are either duly eligible for Medicare and Medicaid or Part D low income subsidy. And if your multiplier is less than 20%, so less than 20% of your patients are in those areas with an index of 85 or greater, you don't get any health equity bonus points. And to get those points, you have to submit all three measures, meet case minimums and data completeness, meet the quality standard. And this is not applied to the web interface reporting as an incentive to get people moving into the CQMs of the APP. This is only given to those who are using the CQMs. So yes, you're right. There's a very specific calculation that gets to the quality performance score, and then two adjustments, that improvement bonus and that health equity adjusted quality performance score.